Good afternoon, everyone, and welcome to the Town Hall, What do COVID-19 Vaccines Mean for Me? My name is André Picard. I'm the Globe and Mail's health columnist, and I'll be your MC and moderator for today's discussion. The Globe and Mail and the Royal Society of Canada have been collaborating for a number of months now on a project called Zero Canada, the Zero Canada Project. It's an initiative that seeks to direct all of us towards the first day that Canada can report zero new cases of COVID-19. I know we're all excited to get to that day sooner, as soon as possible. Now, our hope is that this series of virtual town halls will provide the public with valuable information about the importance of many things, including the coronavirus vaccines. Last month, the Globe science writer Ivan Semeniuk hosted a panel entitled, "How do new vaccines protect against COVID-19?" And a group of leading scientists examined the exciting new mRNA technology, marveled how quickly we were able to produce vaccines, and talked about some of the challenges of getting the vaccine out there. Today, in the second installment of this series, we're going to examine who's getting vaccines, why, what's the impact on different groups, such as residents of long-term care facilities, essential workers, remote Indigenous communities, school children, etc. And finally, on March 23rd, we're going to have a third panel, and it's going to look at the impact of variants, which are changing the discussion a lot. So stay tuned for details on that third panel, which are coming soon. Now, before we get going with today's panel, I have a couple of little housekeeping items. After almost a year of virtual events, we're getting pretty good at this online stuff, but there can be glitches. So if you experience technical difficulties, please let us know. In the bottom left corner, there's an ask box on your screen. That's ASK, unless you in case you misunderstood me, and we'll answer your questions as quickly as possible. You can also use the ask button to ask questions, and I'll try and incorporate them into our discussion today. Now, I want to thank people who sent questions in advance, and many of you did. Dozens and dozens of people have submitted questions. Some people sent 10, 12 questions. So we'll try to tackle as many as possible. And thankfully, we have some themes, some repetition there, so we'll group them together into themes to answer as much as we can. Everyone who registered for today's webcast will receive a link to the recorded version of today's session, so you can view it again. It's going to be something you're going to watch over and over because we're going to be so interesting. And you can, of course, share it with friends, those who aren't lucky enough to be here today. I will also send you some resources. People always, we found, want to leave the panels with some other stuff to bring home and read. So we're going to send you some information about COVID-19, some coverage from the Globe and Mail, information about the Zero Canada Project, some policy briefings from the Royal Society. We'll share with you a chart that we're going to discuss about what are the priorities for vaccination and so on. So the Royal Society has gathered more than 300 Canadian experts from across disciplines to produce independent analysis of the pandemic. So you can take a look at those resources on the RSC website, and we'll send you a link to that as well. And you'll see that link, you can see it up on the screen now if you want to jot it down, but you will be getting it later. I would be remiss, of course, if I didn't take a moment to thank everyone supporting today's webcast. We have several organizations, the Social Sciences and Humanities Research Council, SSHRC, the Natural Sciences and Engineering Research Council, NSERC, and the Canadian Institutes of Health Research, CIHR. At the end of today's event, we're going to have an acronym quiz. So I hope everyone remembered those names and gets the letters in the proper order. A very important thing to know in Canadian science is all your acronyms. Now, finally, if you'd like to follow the social media conversation as well as the video conversation we're having, you can follow the Royal Society, which is at RSC The Academies on Twitter. There'll be live tweets there. There'll also be live tweets from the Globe team. They're at the Globe events. And if you want to follow stuff generally on healthcare, you can find me at Picard on Health, and we put up the Twitter handles of some of our panelists today who have the misfortune of being on Twitter too much with me. Now, without further ado, let's get to the panel. As I said, we have a lot of questions, we have a lot to tackle in the next hour, and luckily we have some very distinguished panelists to help us out. First of all, I'd like to introduce Dr. Christine Chambers. She's the Killam Professor of Psychology and Neuroscience and Pediatrics at Dalhousie University in Halifax, and she's the Scientific Director of the CIHR's Institute of Human Development, Child and Youth Health. Welcome today, Christine. Next, we'd like to welcome Dr. Danièle Behn-Smith. She's the Deputy Provincial Officer in Indigenous Health for BC's Office of the Provincial Health Officer. Everyone knows the Provincial Health Officer, Dr. Bonnie Henry, but she has a great team behind her, including Danièle. She's a member of the Ichu-Dene, the big animal people of the Fort Nelson First Nation, and she has a French-Canadian Métis roots in the Red River Valley. So she knows this country from one end to the other. Also joining us is Dr. Kwame McKenzie. He's the CEO of the Wellesley Institute, an organization working in research and policy to improve health and health equity in Canada. He's also a full professor in the Department of Psychiatry at the University of Toronto. And last but certainly not least, we have with us Dr. Sharon Straus. Among her many hats, she's the physician-in-chief at St. Michael's Hospital in downtown Toronto and the Canada Research Chair in Knowledge Translation and Quality of Care. Now, I have to say that I don't give anyone on the panel justice by those brief bios, but if I read their full bios, we wouldn't have any time to talk about COVID, so we've got them really short to Twitter length. So we're going to take advantage of all their knowledge today and dive right into the questions, because as I mentioned, I have more than 100 here before me, but I've grouped them into categories. And the first category I want to touch on is this issue of priority groups. Essentially, the National Advisory Committee on Immunization has set some standards on who should be vaccinated first. And I wanted to start by discussing who these groups are and why they are first. So I think I'll start with you, Sharon, if I could. At the top of the list is people in long-term care, elders in long-term care. Can you help us understand why are they first? Why is this important to get them vaccinated quickly?
Sure. So thanks very much for the question. And I should start off by saying as well that I'm a geriatrician. So I do focus on looking after people who are over the age of 65, and they happen to be amongst the priority groups that are initially being targeted. Now, there's a national group called NACI, or the National Advisory Committee on Immunization, that's come up with a framework that we've been using in Canada to prioritize who receives the vaccine and when. And in particular, the approach that they've taken is they want to minimize the serious illness and overall deaths from COVID, and also minimize the societal disruption because of the pandemic. And so they've categorized this, and they've identified that the key populations for early immunization are those that are at high risk of severe illness and death from COVID. And in particular, that includes people who are older age and at other high-risk conditions. And then there's also the category of people that are most likely to transmit COVID to those that are at high risk of severe illness and death. And then also the workers that are really essential to maintain our COVID response. So this includes in particular the ones that we've been hearing a lot about in the media and seeing receiving vaccines, including the people in long-term care. And so those are the residents within long-term care, as well as the staff in long-term care. And then there's also people who are in other congregate settings, such as retirement homes, and the essential care workers as well. Then another category of people is the household contacts of those at high risk of severe illness and death. And so those are the populations that you're in particular hearing about now. And then there's also the additional populations that will be coming forward around those contributing to the ongoing maintenance of the other essential services. So it's really thinking about who are the people who are at highest risk of disease and those who are at risk of transmitting it. And then there's also the individuals who, if they're at an elevated risk of infection. And then there's also disproportionate consequences, and that includes the Indigenous communities, which my colleague will speak to.
Yeah, so essentially it's the people, who have been hardest hit by COVID and those at risk of perpetuating the pandemic. We're targeting them first. And exactly. A lot of them happen to be older people, many of them in congregate settings.
Yeah. Exactly.
Now, Danièle, it was just mentioned by Sharon, Indigenous communities are near the top of the list. Can you help us understand why that is? I was just reading an article this morning that proportionally 6 times more Indigenous people have been vaccinated in Canada than in the general population, which is great news. But tell us why they're up at the top of the list.
Yeah, thank you so much for that question, André. And I'd actually like to begin just by acknowledging the strength and resilience of First Nations, Inuit, and Métis peoples in this country. We have rallied and come together in ways to do our best to keep COVID-19 at bay. And I just want to honor all of those efforts at the front lines. The simplest rationale for why Indigenous peoples are being prioritized is that due to colonization and the ongoing systemic racism and discrimination that we experience, we didn't come into this pandemic on equal footing. So we've come into the pandemic carrying the additional burdens and vulnerabilities that stem from decades and centuries of inequity and discrimination. And so what that looks like on the ground is that many of our relatives are living in situations that do make COVID-19 easier to spread. So in situations where there's overcrowding, for example. We also have many relatives who are coming into the pandemic with higher rates of chronic disease at younger ages, which Sharon was just mentioning does put people at higher risk of severe COVID-19. And lastly, and I think possibly most importantly, is that COVID-19 really threatens our cultural continuity. And what I mean by that is that COVID-19 is actually threatening our ability to preserve and pass down the things that make us distinctly ourselves, that make us distinctly Dene, Métis, Cree, Anishinaabe, Hulkaminam, our language, our teachings, our ceremonies. As Sharon just mentioned, this is a virus that has severe consequences in the elderly, including death. And our elders are the heart of our communities. They are often the keepers of our teachings, our stories, and our language. And so we really cannot afford to lose any elders or knowledge keepers to this virus. Our cultural continuity was fragile coming into the pandemic as a result of the attempted cultural genocide of the residential school system. And so I do believe that the vaccines are a very important medicine to help us protect our elders, our families, our communities, and to get through the rest of this pandemic in a good way.
Great. And we'll come back a little later to talk about how those campaigns are going in the Indigenous community so far, but we'll talk about that in a few minutes. Kwame, I want to turn to you. There's calls for, who's next is a big discussion in Canada because we're short of vaccines. We're waiting for them to arrive. Everyone wants them. There have been calls to say we've targeted older people, we've targeted Indigenous communities. What about racialized communities where we're seeing much higher rates of COVID-19? Do they have to be near the top of the list? And I know they are in the NACI, but how do you do that quickly, and how do you ensure the right people get the vaccine?
I think it's quite important that we are rational about who gets the vaccine and who's prioritized. And I do think that the NACI guidelines are really quite good. We want to obviously go to the places where people are at highest risk, and we know that 75% of people who died in the first wave were in long-term care. So it makes sense to immunize people and protect people in long-term care. We know that the Indigenous populations could be at high risk, as Danielle's just been saying, and so it makes sense to go there. And then we should, and we know that we want to protect our hospitals and our hospital staff and our emergency preparedness, because that will save lives. And so it makes sense to be thinking about those populations as well. But one of the other things we know during this pandemic is that racialized groups are 6 to 9 times more likely to be infected with COVID. And if you look at some of the Toronto data, 2 to 3 times more likely to be hospitalized or die. And so it would make sense to start thinking about protecting those populations because they're hard hit populations who are at higher risk. And I think that idea of age being a risk factor, some at-risk populations being that you target, but also some areas, whether you're talking about on reserve or whether you're talking about some parts of some of our cities that have got 10-fold increase in the rates of COVID, would make sense. Those 3 A's, age, at-risk populations, and then area. But you asked me how to do it. And I think one of the things that's important when we're thinking about a diverse strategy, a diverse population, and diversity is supposed to be our strength in Canada, is to have diverse strategies. The online portal is going to be interesting. Also, the telephone portal will be interesting. But one of the things we know about hard-hit communities and diverse populations is that going into communities and building on community strengths is often the way of moving forward. And so there are trusted organizations like community health centers. There are trusted organizations like the YMCA and others who work in communities all the time that we might want to build our vaccine response partially on in order to meet the needs of those communities. But having conversations with communities about what would work best is a good way forward.
Great. And we'll talk about that, some of the strategies that are important to reach different groups within diverse Canada. Christine, a slightly different question for you, because a lot of people say, geez, I look at this big long chart here that I have, and where are the kids? When are the kids going to get vaccinated?
Yeah, so while children and families have been enormously impacted by this pandemic in terms of school disruption and, caregiving disruption, the reality is that children are at relatively low risk of disease, serious disease, death. And so they are not at the front of the line when it comes to the vaccination rollout. And in fact, people will say to me, it's not even authorized for use in children. And I say, well, that's not because it hasn't been found to be safe. Those studies are just starting to happen now. So the Oxford AstraZeneca vaccine, they're currently testing in children as young as 6 years of age. Pfizer, Moderna are, just starting trials and have enrolled participants as young as 12. So, children respond differently to medications than adults. And so medicines do need to be studied, and formulated for children. So this is something that is certainly moving forward. And I would say it's not an indication that it's not safe at all, that those studies are underway and that work is being done.
But what about say kids with disabilities and their caregivers? Should they be up? Are they up higher on the list?
Yeah, certainly this is something that is being discussed and is being considered in terms of the added risk of that intersectionality of disability and age. Lots of complex factors here that influence any one person's risk.
Great. Now, Sharon, I want to come back to you. A lot of the questions are about, you explained very well the list, why we have this rationale of who gets vaccinated first. But a lot of our question is, when am I going to get it? How can I find out where am I in the queue? People don't necessarily want to bump to the front. They just want to know. They want some sense of when's my vaccine coming? Can we figure that out yet? Do we have enough information to know that?
So it's a great question. I think I get emails constantly every day about, when am I going to get my vaccine? How am I going to get it? Who's going to call me? That's one of the commonest questions that come up. And I wish I could answer it with something beyond, I don't know. I think that there's a couple of things to keep in mind. One is that, there is the priority process that's coming through from NACI, and then each of the provinces then and territories has a process for implementing it as well that we have to consider. But then the second piece is that we've heard a lot about is around the supply chain side of things. And so that's really the rate limiting step that has been the challenge up until now. And that's influencing, the next steps going forward. Certainly one of the things that we recently had released in Ontario is that they've identified kind of what's going to happen in the stage 2. And I know that in other provinces, they're similarly doing that as well. And they've identified in the next group of people that it's going to be, for example, older people over the age of 80 living in the community, and then they're going to go down by every 5 years after that. And those are posted on the various provincial and territorial websites for the Ministries of Health. And so I would encourage people to look there. I would also encourage people to look at the Health Canada website on the COVID vaccine. It's a fantastic website. And it not only includes the prioritization process that we've talked about, but it also gives you an update on how many people have been vaccinated across the country and the % of adverse events that have been noted as well.
Right. Yeah, I think, as you mentioned, there's lots of moving parts, right? We don't know exactly when the vaccine arrives, so it's hard to say when it'll be administered. I found a little app where I punched in my info and it said I was 22.4 millionth in line, so I'm getting pretty excited. I should get it around July or August if things remain the same, but we know we may get additional vaccines. Those schedules may change. But Kwame, I want to talk about the rollout. You mentioned, it's hard to tell, that question about when will I get it and how do we communicate this? We do, as you mentioned, we do need different strategies for different groups, right? I'm watching what's unfolding in the US, and just saying that everybody has to register online is not necessarily fair, right?
Definitely not fair. We know that there is a digital divide, and that digital divide is partly due to who's got access to broadband, who's got access to a computer, but also who's computer literate. And those things are patterned partly by income, but also by whether you're a member of a racialized group or not. It can be difficult to get information and get online and get in a queue if you are a person who doesn't speak English or French, or if you speak English or French, but that's not your first language and you are not comfortable reading English or French. And so just having one website and saying everybody get on the website has proved in other countries such as the US to lead to prioritization by education and race, with more educated white people who speak English getting to the front of the queue. So I think we need to be thinking of multiple ways of people being able to sign up and get in line. And sometimes, websites are good, but telephone lines can work as long as they're properly staffed and people aren't using the whole of their pay-as-you-go minutes waiting in a queue to try and get a sign up. But I think we also need to give opportunities for communities, for people in communities to either sign up in person somewhere or sign up at work, because some people are working very hard and the opportunity to get onto a computer, get onto the phone, or even go and sign up in person is going to be difficult. It's interesting in the UK, your family doctor gets in contact with you and tells you can now sign up. And so there's a reach out to you, which is an interesting turnaround, that family doctors are actually reaching out to people. Both two of my brothers have both had their first vaccinations in the UK system, and it was their family doctor who got in contact with them and said, you are now able to sign up. And that facilitated their process of getting their first inoculations.
Yeah, it'd be interesting. I'm not sure that we have the electronic health records in Canada to do that. And I'm not sure everyone has a fax machine at their home to get information from a doctor, but we'll certainly have to work on that communication part.
Oh, I'm sorry. They were texted. It was a text, not a fax. Yeah. Faxes, I'm surprised. Do they still exist, André?
Only in Canadian healthcare. Yes.
Oh, I see.
So Danièle, I thought I want to talk to you a bit about in some Indigenous communities, how the rollout has worked, how you've rallied people. I've seen some very moving scenes on the news of people greeting the plane coming with the vaccines, sending them off with great, almost a parade to thank them. How's that rollout going, and how have you convinced people who are sometimes a little hesitant about this?
Yeah, thanks, André. I would say there's a very broad spectrum in terms of vaccine confidence across diverse Indigenous communities around the country. And I can speak to our experience here in BC and feel so grateful that we have such strong relationships and such a strong Indigenous health landscape with the First Nations Health Authority and Métis Nation BC, and having strong relationships with both organizations to really facilitate getting the vaccine out to Indigenous peoples in an early and effective and culturally safe way. And so, as I was saying earlier, there is such an opportunity, I think, for these vaccines to be embraced as critical medicines that can help protect us and protect our cultural continuity. It's really important. And yet at the same time, we have elders who in their living memory recall going into segregated doctors' offices in Duncan, BC, for example, who remember undergoing inhumane and unethical research in the name of health, who recall undergoing forced sterilization without their knowledge and consent. So there is definitely a lot of fear and distrust that is out there in our communities, and it's very understandable. We continue to have experiences of interpersonal racism in healthcare settings across this country. And so I guess as I think about some of those successful rollouts and experiences, when I think about what made that possible, I really see it as our communities coming together and standing strong in our mucklucks, in our moccasins, in our teachings, and using this opportunity to bring the healing medicines that we have that have kept us strong for centuries and thousands of years, and really bring that gratitude and humility to these medicines, and try and bring all the benefit that they have to offer and leave the negative side effects behind. That said, the trust deficit is an enormous challenge, and one of the ways that we're trying to address that here in BC is by finding ways to come together virtually, of course, and saturate that network, that moccasin telegraph, with reputable and good sources of information to counter and hopefully diminish some of that fear and distrust.
Great, thanks. Christine, you're in the Atlantic bubble, living the good life, unlike some people in the rest of Canada. Have people sort of taken vaccination for granted because COVID has not hit that hard there, or what's the reaction been like there?
Yeah, no, I think despite our Atlantic bubble, and certainly we're seeing, some changes in that status. So I think there's a lot of urgency and concern around the need for the vaccination. And so I don't think we felt any more insulated or that it's not as necessary. I think, if anything, that there's just such a strong sense around needing to adopt and embrace the vaccine as quickly as possible, along with the rest of the Canada. I think we realize that while we may be in different regions with different impacts, we are all in this together, and we need to have a coordinated approach and collaborative approach to this.
And Christine, while I have you, I want to turn to a different topic, a different area. Lots and lots of questions are just about the vaccine itself. Does it hurt? Can I get it if I'm pregnant, etc.? But I know you're an expert in the pain aspect. It doesn't have to hurt campaign has gone viral around the world. Tell us what we can do to encourage people to get vaccinated who are afraid of that needle. There's so many of us who have needle phobia, who think it's going to hurt. What can we do practically about that part of it?
Yeah, it's a great point. I mean, there's lots of reasons why people are vaccine hesitant, but one of the reasons is that they're afraid of needles, and often people are afraid to tell this. People will confide this in me almost like they're embarrassed to admit. We know that 1 in 10 adults has a fear enough of needles that it interferes with their engagement with healthcare and impacts their medical care. So there's sort of two pieces to this. One is the managing the pain associated with needles. And pain is a very subjective experience. And so it varies from person to person. So some people say, the vaccination might hurt a little, and some might say it hurts a lot. And that's just the way pain works. There's lots of, things both internally and externally that impact how painful an event is. In terms of managing pain from vaccination, this is an area we have a lot of solutions for. My colleagues, Anna Taddeo, Megan McMurtry, published a clinical practice guideline with evidence-based recommendations back in 2015 in the Canadian Medical Association Journal. And some of these strategies are so simple. Many of them have emanated from the pediatric literature, but they do work with adults too. So simply making sure you're distracted when you're getting a needle, using relaxation strategies. There's a topical anesthetic creams that you can buy at the local pharmacy and apply on your arm or injection site about an hour before the procedure, and this numbs the pain. So those are all things that you can do to manage the pain. But of course, sometimes your fear or anxiety is so great that even those simple pain management strategies don't work. And, this is not where someone needs to suffer in silence. There are lots of ways that psychologists, I'm a clinical psychologist, can support people in overcoming their fears. But the basic principle is that, fear avoidance, fuels anxiety. So helping people to gradually face their fears and supporting them through positive vaccination experiences is really critical.
I know every time I get a vaccine, I reward myself with a really nice meal. So I think that kind of helps with my pain. I'm not sure if that's one of your tips, but it works for me. Now, Kwame, we're talking about vaccine hesitancy. Christine used that term a couple of times. We know that most people aren't anti-vaccine, but people have doubts for a whole bunch of reasons. Can you talk a bit about, Danièle referred to, Indigenous communities, they have bad experiences with the health system. Is that an issue as well in some communities, racialized communities have not necessarily had the best treatment in our health system? Will that keep them away from getting vaccinated?
It may well do. At the start of at the end of wave one, when people were looking at rates of vaccine hesitancy in Canada, they were showing that the rates of vaccine hesitancy were highest in the Black population. Excuse me. In fact, only 38% of the Black population of Canada said that they were likely to get vaccinated in one of the initial studies, and that was the lowest rate of any population. Over periods of time, since the vaccine has come out and since people have been seeing that, people have been rushing to get vaccinated worldwide, that we haven't seen very many side effects at all. And some of the work that's coming out of Israel and also from the UK and also from BC is very significant impacts on decreasing hospitalizations and deaths. More and more people are more confident about the vaccine, and vaccine hesitancy has been going down across the board, including in the Black population of Canada. And yes, you're right. Part of the reason for people being worried is, just as Danièle was saying, trust issues. Whether the health service has been there for them in the past. Some of the Tuskegee affair in the United States, where there was experimentation on Black populations, and also some experimentation that's happened here. So there are trust issues for the Black population with the health service and with vaccination. But as people are seeing that the vaccine works so well, the hesitancy rates seem to be, according to some of the studies, decreasing. That doesn't mean that we are out of the woods yet. And it really does mean that we really need to be thinking about how we get the information to racialized populations in ways that are accessible from trusted sources, so people can have all the information they need to make up their own minds. I think it's very important that, even though it may be somebody like me who's sort of very convinced that vaccines are the way forward, that we don't try and pressure people into this, and that we give people the information and let people make up their own minds. From my perspective, I think it's a very clear argument and very clear case that vaccines are the way we are going to get out of this with other public health measures. But, we have to respect that other people may have different opinions.
And Sharon, we're on this vaccine hesitancy question. We're getting a few questions which essentially say, I'm paraphrasing a bit, but if this vaccine's so great, why are there some doctors and nurses and personal support workers who don't want it? Why are the people most at risk? Why are some of them hesitant?
Yeah, so it's a great question, and we certainly have heard that as well, and we've done some work to try and identify kind of what are the sources of concerns that people have, and what are the questions that they have. And there's a few things that have come up quite commonly, and I think some of it is what Kwame and Danièle spoke to already about the trust and maybe not trusting the policymakers and the decision makers who are coming out with the information around the vaccine. So I think that's a common issue that's come up. But other issues that have come up around how quickly it seemed that the vaccines were approved. And so I think that there's a lot of work that we need to do to explain the process of vaccine approval, and to say that there weren't any steps that were missed or anything. That it was really a very efficient process and a rolling process of looking at the evidence within Health Canada, but that there were no shortcuts taken or steps that were removed from the approval process. So I think that's one of the commonest questions that we have around how quickly they were approved. Some of the other things that have come up around questions and concerns that people have are around how safe it is and what are the risks of adverse events. And again, if you look at the millions and millions of doses that have been given worldwide, the number of adverse events is really quite small. And I think that's really encouraging, and in particular around the severe adverse events. So I think those are some of the things that we need to make sure that people are aware of. And then there's a lot of myths and misperceptions that are out there as well, and a lot of these kind of get perpetuated on various social media and things around anything from is there a microchip in the vaccine, to whether or not that the vaccines were produced with fetal tissue or with animal products. So there's a lot of questions related to that that we really require myth busting to say, there is no microchip that's part of the vaccine. And I think that Jennifer Gates had an interesting tweet recently where she said, she got her vaccine as a medical student, and she can attest that her dad did not put a microchip in it. So I think that there's a lot of myths that are out there now that we really need to make sure that people have the right information that they need to make an informed decision.
Okay. And I'm going to come back to some of those technical questions in a minute, but I know that you've gotten your 2 shots, so people want to know, how is it? Is it, because we hear a lot of things, it hurts, the second shot hurts more. Are these things true?
So I can say for me, it was true. I just got my second dose yesterday, and I was saying to the panel before we started that it was just an exciting day. It was just felt so fantastic to get dose number 2. It was delayed by a couple of weeks because of the supply chain challenges, but it was fantastic. And so the second dose did hurt more. So I actually have a sore arm today, whereas dose 1, I didn't feel it at all. Dose 2 did hurt more, but aside from that, I have not had any other adverse events. And about 3/4 of people complain of having more pain with the second dose. So and if that happens, and we talked before about strategies, but have it in your non-dominant arm, for example, and if you want, take a little bit of Tylenol or acetaminophen or ibuprofen for pain relief if it's really bad. But I also think, for me mentally, it's a reminder that I got the vaccine, and I just kind of imagine my immune system setting up the fight. So that's how I kind of have been perceiving it.
Okay. Kwame, you want to jump in there?
I wanted to ask Sharon a question, because some of the studies I've seen of medical personnel haven't actually said they don't, the majority say, yes, I'm going to get vaccinated. And then some people say, yes, I'm going to get vaccinated, but I want to wait. And then actually quite a small number say, no, I'm not going to get vaccinated. Is that what you found in your studies as well?
So it's interesting. We're seeing a pretty substantial uptake amongst the physician groups, and then amongst other healthcare providers, we're seeing less uptake. So not to the same levels amongst physicians. When you look at kind of what people are saying, so you're absolutely right that what we're seeing is some people saying, you know, I'm just not sure at this point whether I want it or not. You know, maybe I want to wait to see kind of what happens and how things evolve. So I think, you know, it's very much similar to what you've identified, but we also are seeing differences across the types of providers that are being surveyed.
And Christine, I'll get you to jump in because one of our listeners is asking, like, why does it hurt? I understand it's the adjuvants that make the pain. Is that correct?
Yeah, there's lots of factors that impact how much it hurts. That can be one of them, the location of where it's injected, the size of the needle, you know, pH level of the solution that can be acidic. So there's a variety of factors that influence that. Those are external factors, but again, you know, there are those internal factors. If you're more anxious when you go to get the vaccination, it will hurt more. We know this about how pain works. So really important to manage the factors that you have control over.
And I'll keep you for lots of questions about pregnancy. Can people get the vaccine if they're pregnant? Is it going to affect their fertility? Will it affect the baby, the fetus? What do we know about that?
Yeah, this is such a hot topic and people do have a lot of questions. So when the clinical trials are initially set up to test the vaccines, pregnant women are actually excluded, again, for, you know, the same reasons that children are not first in line for testing. But however, we do end up, you know, people who enroll in trials become pregnant even though they might not have been expecting to. So there is some small data available, you know, and very, very limited to say, you know, to indicate that so far there don't seem to be any negative impacts, but it's very preliminary. Just like the trials that are starting on children, the trials are starting on pregnant women now. But a lot of different groups, including the Society of Obstetricians and Gynecologists of Canada, have released statements and made recommendations. And I think the general consensus is that it should be a personal choice, that, you know, pregnant women should be offered the opportunity for the vaccine. And certainly we know that, you know, pregnant women who contract COVID-19 are at great risk of, you know, pregnancy loss, preterm labor. So it's really, you know, being presented as something that should be the personal choice of the woman who can make a decision based on the evidence available. But certainly, you know, this whole, you know, the questions around inclusion of children in clinical research, inclusion of pregnant women, there's some bigger issues here around how we conduct science in these populations that I think this pandemic is shining a spotlight on that we will need to address moving forward in a more inclusive way, that we need to make sure our science is as inclusive as possible.
And Danièle, I wondered if maybe you could weigh in on this. I know the First Nations, Inuit, Métis communities are very young communities. Lots of the birth rate is much higher than the general population. Does that concern, that hesitation exist in those communities as well about the vaccine?
Oh, absolutely. When it comes to those reproductive years, you know, we're very, very attentive and mindful to those years and recognize it as a very special, sacred time. So people are most definitely following that and tracking that evidence and that science. And I think what's come up for me in listening to my fellow panelists just now, and especially to Christine's comment, is thinking about something that I've heard from my colleagues, Dr. Janet Smiley and Dr. Sarah Funnell, referring to COVID-19 as a trickster or a tricky relative that's sent here to teach us things. And so, you know, as I think about that, I really think about this, that one of the most important teachings is about balance. And so when I'm talking with my family members or I'm hearing the chatter from other communities about fears around the vaccine or vaccine hesitance. It seems to be that conversation is lacking some of the balance, and that there's, a tremendous amount of fear and distrust about the vaccine, but it's to the exclusion of what we know about the impacts of COVID-19, which I spoke to earlier, which really does pose a threat to our cultural continuity. So our efforts are really about trying to get that information out in a more balanced way so that people can acknowledge that this isn't, that there are risks potentially on either side. The vaccines to date have been proven to be very safe and very effective. We know the risks of COVID-19. And so to Kwame's point earlier, many of our communities hold that ethic of non-interference and really value a person's autonomy and self-determination. So we want to follow and support people on their journeys, and at the same time be there for women who are pregnant and for children and families to be able to walk alongside them and provide all that very evidence-based information so they can make the right decision for themselves and their families.
Okay. And Sharon, I'm going to go back to you because we have a lot of questions sort of aimed at the geriatrician on the panel. So lots of questions about immunocompromised older people, with diabetes, with cancer, heart disease. All of them have little worries about, well, is it safe for me to get the vaccine? What can we tell them?
So absolutely, and these are common questions that I hear about in my patient population is, if I have cancer or if I have multiple sclerosis or whatever, can I get the vaccine? And number one, I would say, discuss it with your primary care clinician. So to make sure that you get the, and really enter into a shared decision-making conversation. But overall, it's safe to get. And so none of these conditions should preclude you from receiving the vaccine. And really there's only two contraindications. And so one is if you have a severe anaphylactic reaction to PEG or the polysorbate that's in one of the vaccines. And that would be, one of the potentials. And then the other one is that we've already talked about is the age. So because they've not yet been approved in the under 18 or under 16, depending on the vaccine. But aside from that, they're safe for people. But if you do have any questions or concerns, I would always encourage people to speak to their primary care clinicians about it.
And related to this one, and you alluded to it already, lots of questions about allergies. If I'm allergic to all kinds of things, is it safe? You mentioned eggs. Is there any other?
So it's not made with eggs. It's not made with any pork, any animal products, no gelatin in it. So there's no concerns about any of that. The only thing that people have suggested that if you've had an mRNA vaccine before and you've had an allergic response to it, then you should see a healthcare provider about it. And really that's the only thing.
And there are very few mRNA vaccines out there.
Exactly.
So that's
Exactly.
Kwame, one of our very astute viewers is pointing out to me that I've asked you about racialized communities, but I've been very neglectful talking about poorer communities, the homeless, et cetera. You have a lot of expertise in that area. How can we ensure those vulnerable communities also get outreach because in many cases we're going to have to go find them, right? They're not going to be reading on the internet that the clinic's open tomorrow at noon.
Yeah, and I agree with the question. It's a really important question that we have homeless populations that are high risk, and that when we're thinking about high risk communities, we should be thinking about those populations as well. And it's again some of the same ideas of you can try and guess, or you can work with either people who work with homeless populations and low-income populations, or people from low-income populations or homeless, and find out what is going to work best, how you're going to be able to reach those populations best. And I think it's the same model. I did just want to pick up on one thing, going back to what Sharon was saying about people with chronic diseases. My calculation from everything that I've read and everything I've seen is that the risk of getting COVID is probably significantly higher than the risk of getting the vaccine. And so when people are trying to make their decisions, if you've got severe diabetes, your risk of getting COVID is going to be much higher, and your risk of a bad outcome from COVID is going to be much, much higher than any risk that comes from the vaccine. And I think that people need to balance that up and make their decisions. But these vaccines, so far, the evidence is they're very, very safe.
And Christine, I see you nodding. I think that's a big aspect of many of your campaigns to remind people that the diseases that vaccines protect from are way, way more dangerous than vaccines. Maybe we can talk about that a bit.
Yeah, absolutely. And this brings to mind the important point of, the impact that this pandemic has had on parents seeking regular routine healthcare for their children. So, while we're waiting for the vaccine for children, the COVID vaccine for children, please, parents, make sure you're taking your children in for their routine vaccinations. This is still safe and very important. And, we don't want to be so focused on COVID that we inadvertently lose all the progress that we've made with other infectious diseases by having, a strong public support of vaccination for other diseases.
Yeah, really good point. We're so focused on this COVID vaccine that we forget about other things. And the other thing we shouldn't forget is the measures that have worked all along still work, right? And they're still necessary. We still need to wear our masks and do the physical distancing, et cetera, to keep ourselves safe while waiting. And Sharon, that brings me to a lot of people are wondering, is the vaccine going to get us out of all this? When can we go party again? If I'm paraphrasing some of the questions.
Again, it's one of those things that I wish I could tell you a date. And maybe we can set a pool up afterwards amongst the panelists and get that going. But I think one of the things to keep in mind is that despite having the vaccine, we still need to maintain all the appropriate precautions. So we still wear masks. We still maintain appropriate physical distancing. We still maintain appropriate hand hygiene. I can't fail to emphasize that enough, that those measures still need to be implemented. And keeping in mind that, it's going to take a long time to get everybody vaccinated. We're also going to have to be doing, ongoing studies looking to see how long the immunity lasts over time as well. So there's a lot of different factors that we have to keep in mind. And I would just encourage people to see this as, there's light at the end of this very long tunnel. There's also, more promising therapies that are now available than when we started out a year ago. We're in a very, very different place, but there's still a ways ahead of us before we can all kind of, take off the masks and hug somebody again who we're not in the same household with.
Okay. And I think I'll stay with you because we have some fairly technical questions too. People are wondering, they keep reading headlines about, is one shot enough? Do I have to go for that second shot? Can I mix doses? Can you address some of those technical questions?
Yeah, so great questions, and certainly with both the Pfizer and the Moderna vaccines, which are the two vaccines that are approved for use in Canada, they are both two-shot vaccines. There's been a lot of discussion around, the original trials showed a different time period between dose 1 and dose 2 than what's sometimes happened because of the supply chain issues. Modeling has suggested that even up to 42 days between dose 1 and dose 2, you can see the same effectiveness, so same vaccine efficacy. So I think that we really want to reassure people about that. Also want to reassure people by the experience with the vaccine in Israel and the UK around what they're seeing in terms of the delays between dose 1 and dose 2. One of the newer vaccines, so the Johnson & Johnson is a 1-dose vaccine, but that's not been approved yet for use in Canada. But currently the recommendation is the 2 doses. Whether you can mix, and so there have been a few people that, dose 1 was Pfizer, dose 2 was Moderna, and it's happened just because of kind of mix-ups and things. There's no evidence to say that that's going to change the effectiveness of in any way, but definitely the recommendation is that you get the same type of vaccine in dose 1 and dose 2.
And I think implicit in all your answers is there's a lot of, we're just learning stuff, right? This is all brand new. We're learning as we go along.
Exactly. And I think, again, we're learning every day from not just what's going on in Canada, but our colleagues in other countries. And, the Israeli data has been really, really interesting, and similarly the data in the UK. So I would encourage people to keep watching this space, because we're constantly learning.
And Danièle, I see you want to jump in there.
I did. Just for a moment, thank you. I just wanted to add that some researchers from here in BC have just published an op-ed in the New England Journal of Medicine talking specifically about that vaccine efficacy with 1 dose, and showing that it does, a few weeks after the vaccine does climb upwards of, 80 to 90%. And so I think it's really important for us to remember as well that this is a population level program. We're trying to protect as many people as possible, as quickly as possible. And so there is quite a strong rationale for getting as many first doses in arms as possible, and then possibly pushing out that second dose a little bit. And as Sharon was just saying, in terms of the overall success of the vaccine, we know that delaying a little bit doesn't interfere with that efficacy. We also know that you get significant protection with that first dose. And so I think that's really been one of the things that's informed decision makers as we try and get as many first doses into arms as possible. So I just wanted to add that little piece as well.
That's great. Now we're almost out of time. I always like to end our panels on a hopeful note so people don't leave too depressed during these COVID times. So I want to ask each of you, what's giving you hope these days about the pandemic going forward? Maybe Kwame, you can kick us off with some inspiring words.
I'm not sure that I've got inspiring words. But I have got the truth, and the truth is that if people told us a year ago that we would be in this position, we would be rolling out vaccine, we would be seeing that we know likely during summer and then after that we're going to have fewer restrictions, that the world has got together to produce a number of different vaccines, and then on top of that we've got new treatments that seem to be decreasing the severity of the illness and increasing the chance of survival. We'd probably say that we were, as a world, working together in a way that we'd never worked before. And that is what's happened. It's been a terrible but exciting time where we've done things we've never done before. And if we can build on that, and if we can keep ourselves safe for a few more months, then we're not going to just say suddenly it's all fixed, but we'll be on the right trajectory. And so I'm very optimistic because of that.
Wow, that is very optimistic. Your many wise words. It'll be hard for the other panelists to top that. Christine, you give it a try. What gives you hope going forward?
Well, I think what we've seen this year is a real success story for science, right? At how quickly, the global science community has been able to engage and come together. I would also say that there's new opportunities now for, science communication. And this is a great example today of making science and evidence more accessible to the public. I think also we've learned what wasn't working before COVID, and we have an opportunity for children and families in particular to build back better from this. So I have hope beyond.
Now, Danièle, we don't always have hopeful news out of Indigenous communities. What's giving you hope these days?
I take great strength in the teachings that I've received from so many elders and knowledge keepers around really looking, as Kwame was just talking about, looking for the gifts and teachings in the hard times that we're working our way through. And so I think one of the most profound gifts that I've seen and that I'm really holding on to dearly is watching reconciliation in action. Pandemics are unprecedented in our communities. We've been differentially and negatively impacted by them countless times in the past. And what I've seen happen through COVID is that we're coming together, we're working together in different ways. It's not been seamless. There have been bumps along the road, and yet we continue to forge those relationships and keep coming together in good ways. And I know we're all tired and we're all looking forward to a time when we can go back to something a little bit more normal. And at the same time, I think we're paving ways to address these long-standing inequities that COVID-19 has illuminated for us. And we're really creating processes and protocols and new ways of working that are going to stand us in good stead to the end of this second wave, but also into the future. Masicho.
Thank you. Sharon, the final word, what's giving you hope looking forward?
What a tough act to follow. Everybody had such fantastic things and really resonate. So I guess I would say two things. One is echoing what Kwame said, and I feel as a clinician, I have more things in my toolbox now that I can offer to patients. And I think that to me is just one of the most amazing things when I contrast to a year ago when this all started and like we had nothing, right? And so now being able to not just have the vaccine, but also have interventions now, that are really making a difference to patients in the ICU as well as on the inpatient ward. And I think that's a tremendous thing. And then the second thing is, I feel really, really privileged to do what I get to do every day. And one of the things is being witness to the kindness and the collegiality and the professionalism that I see day after day after day. And the kindness that everybody has shown through this period of the pandemic, and the commitment to solving these big challenges that everybody's talked about today. And I think it's just really quite inspirational.
All right, thank you. Lovely to end on a note of kindness is a good word to end on. And on behalf of the Globe and the Royal Society of Canada, I want to kindly thank the panelists for joining us today, taking time out of their busy schedules, especially the parents among the group who I know have extra burdens during the pandemic. A big thank you to our sponsors, the alphabet soup of sponsors, the SSHRC, NSERC, CIHR, and the Royal Society. And a reminder to the audience that you'll receive a link to this recorded webcast. Please share it with others. They can share in the wisdom we heard today. And thank you, of course, the audience for being there, for your tough questions. And we hope to see you again at our next panel in the series. It'll be on March 23rd. So everyone, please stay safe, get your vaccine, and be back and be well.